Gender Queries, a podcast exploring trans and gender diverse healthcare in Atlantic Canada. My name is Sam, my pronouns are they, them.
I'm Jess, I use they and she pronouns.
And I'm AJ, and I use he, they pronouns.
Today we're talking about something that shapes nearly every trans patient's health experience, and that's provider education. Across Canada, medical education on trans and gender diverse healthcare is still evolving. In a lot of programs, the topic might come up in a single lecture, a short workshop, or maybe a small section within a broader 2S LGBTQIA+ module itself. And while those sessions are definitely a step in the right direction, they often don't fully prepare clinicians for what it actually looks like to provide gender-affirming care in real clinical practice.
My name is Victoria Brown, and I use she, her pronouns. I do remember a couple of small group sessions, especially in skilled clinician, so where we focused on more of our communication skills. We were encouraged to introduce ourselves with our own pronouns and then also invited the patients to share their own pronouns. We also talked during these sessions about using more inclusive language for anatomy. So, for example, asking patients what terms they would prefer for certain body parts. So it helped us think more intentionally about how to make people feel respected in those potentially difficult clinical conversations. But I will say there wasn't much content on specific medical care for trans patients, but those sessions helped lay more of a foundation for respectful interactions. So it gave us language and awareness, but not a lot of depth about actual medical care, transition-related treatments, how to navigate real-life scenarios in clinic.
Hi, my name is RJ, and my pronouns are he, him. I am a medical student. I'm also a wheelchair user and identify as a trans man. I can see why my providers aren't always so knowledgeable because we've completed our official classroom textbook learning units. And obviously you learn a lot in practice, but I do think that there was very little that touched on trans care. There's nuanced discussion that you're going to have with your patients. And I don't think that the curriculum fully is able to even explore that. I also know that the curriculum is packed. Mm-hmm. And it's like, where do you put it in? How do we incorporate it? Ultimately, for the patient's care, and then also for the provider's comfortability in providing that care.
Mm-hmm.
This is an issue across all health programs.
My name's Amy Prescott. My pronouns are she, ze. I'm genderqueer and I'm a physiotherapist. Unless you go out of your way to learn that information, it's just not being taught to you in a very broad sense.
My name's Xiaoqi. I use he, they pronouns. I've been a registered nurse for the last 10 years or so.
Do you feel like what you learned in school was adequate?
I'm sorry. Enough said. The fact that we're doing this interview already, I think we are both very much in the know of that it's not adequate. I also did my learning 10 years ago. So it's been a fair amount of time. I am but an old man at this point. But right now, I find as research comes out and as we're able to create teaching material, by the time we get it peer reviewed and out to the public and out to the population that we're trying to educate, it's all pretty outdated.
Do you think that having you be on the team has changed the way that your colleagues interact with patients?
Yeah, I want to say for sure, not to be like I'm amazing, nothing like that. But I think it's just made folks a little more aware of where they maybe didn't know anybody who was gender nonconforming or transgender before to be like, oh shit, that's right. These people exist. They're my friends, they're my family, they're my colleagues. So maybe something that I would have said or assumed before, not out of maliciousness or anything like that, but take a second thought. Because, hey, Xiaoqi's standing next to me and he said to me last week that this is something that we, maybe shouldn't say or that it could be uncomfortable to a patient that's coming up. I have a really good colleague friend of mine. She often jokes, she's like, Judgy, you being transgender in the department really has done more for everyone's learning than anything else. I'm just like, oh, thank you. But it is what it is, right? You don't know what it is until it happens to you or someone around you. I feel like people are generally more not careful, not on their tiptoes. I don't want to say that, but definitely more conscious.
Transgender health education is often fragmented and rarely actually integrated throughout the curriculum in a meaningful way. It's something that we see within research from medical schools across Canada. Instead of being taught as a core part of medicine, it often ends up being treated as this optional topic or something that's really just added in on the margins. There are a few reasons for that. Some of the research shows that many institutions report that faculty may not have a lot of experience teaching this material. There aren't always accessible teaching resources available for them, and the medical curriculum is already incredibly packed.
My name is Gabriel Enxuga. I use he, they pronouns. I'm a social worker and I work as a navigator with Pride Health. One of the things that I notice is really just a lack of training and competency, or I would say also more like confidence among healthcare providers to provide gender affirming care. I think there are a lot of providers who would like to provide it, but just haven't received training in that area. They didn't necessarily receive it during medical school or in other aspects of their education. So within Nova Scotia Health, gender affirming care is considered to be within the scope of primary care. And according to the gender affirming care policy put out by the Department of Health and Wellness, it's also considered to be within the scope of primary care. But providers don't always have the knowledge or experience to feel like they can do it confidently. We don't have data on this. We're actually going to start tracking it, but to see how many people are referred to us who already have primary care providers, but are still looking to access gender affirming care through another provider. So I say that is a really big gap. And that's something that we are looking at through our education strategy to provide continuing professional development training to providers to really enable them to feel confident to provide that care.
What do you think are some of the consequences when it comes to providers feeling either unprepared or not having the adequate amount of education?
I guess that it creates unnecessary barriers. For example, unnecessary referrals because someone doesn't feel comfortable with it, even though it's within their scope of practice, which in a system that is already overwhelmed just means that folks end up waiting longer for care than they need to. Whereas if every family physician was comfortable with it, then more folks would be able to get that care more quickly.
Yeah, exactly. And I was speaking with one of our guests, Nikki, and she talked about how she was denied care from her family physician despite having a letter of readiness, which is a document written by a qualified mental health professional to support a patient's access to gender-affirming medical care. At the time, it was required for initiating hormone therapy.
My name's Nikki Valentine, pronoun she, her. I am a trans woman from Cumberland County, Nova Scotia. Essentially what happened was my specialist just provided me the letter and some copies of the letter to send. I mailed it in and I got it mailed back that he wasn't able to provide my care for that. It was a little strange that he wasn't like, here are some other options for you to access care. It was tough knowing that my family doctor wasn't able to provide me that care at that time. I didn't really feel the need to continue seeing him after that because I was like, well, then you're going to be very unfamiliar with an entire path of my healthcare.
We also hear from Aspen, a trans woman who had a similar experience in being denied care by her family physician.
My GP gave me some prescriptions for antidepressants to help treat my gender dysphoria and just general anxiety. But she said immediately, I can't help with HRT. I can't help with hormones. It's not something I know about. And because of that, I'm referring you to an endocrinologist in your area. It created a bit of a socially awkward chasm in the relationship. I never really got the feeling that she was affirming beyond what human rights would require. That being said, doctors don't necessarily have to agree with their patients or their patients' realities, but they have to treat the problems.
These kinds of experiences are not uncommon. Many trans patients are referred to specialists for care that family physicians are actually trained and able to provide, and that referral culture can create these unnecessary barriers and long wait times, and it's something that people working in trans health navigation see all the time.
My name is Jocelyn Adams. Pronouns are she, her, and I'm the Executive Director of Gender Affirming Care Prince Edward Island and one of the co-founders of Gender Affirming Care Prince Edward Island. One of the big barriers in our province is confidence. This is stuff that should be with your primary care provider. So there should be no referral required unless there is a specific complex need associated with it. This is stuff that stays with primary care. This is not specialty stuff. But because we have a clinic now on PEI, and because we have this confidence issue with physicians and nurse practitioners, they go, we have a clinic now. I don't have to think about this. And they send off a referral. And we try to keep that from happening. And the clinic also doesn't want that happening because their wait times are going up. They're doing basic blood work and it's like 6 months wait.
Gender affirming care isn't meant to be something that patients are automatically referred away for. And when it is, we see those wait times grow and we see access getting harder than it already is. But I think it's important to acknowledge the reality on the provider side in that for many clinicians, they may have had little to no formal education in gender affirming care. It can make stepping into it feel really uncertain and even intimidating.
My name's Dr. Sue Atkinson. I'm a family doctor. I work at Dalhousie Family Medicine and also the Halifax Sexual Health Center. And I've been providing gender affirming care for probably 30 years now. It can feel a little medically scary at first, but it's not. And, it's just a matter of sort of having an approach like anything else. But also with the recognition, for some people, it's completely unfamiliar. So when I went through medical school, we learned nothing about gender affirming care. So people of my generation have never learned anything at all, right? It feels foreign and scary and like, I don't know anything about that. And I don't want to hurt anybody. I don't want to do harm. So part of it is people either seeking out or being provided with the education. And most people will have someone in their practice who needs injectable testosterone because they have hypogonadism. And most people will be prescribing estrogen as either menopause hormone therapy or contraception. We know about those medications. We know the risks and the benefits and the side effects and all that kind of stuff. So it's not completely foreign. It's just a matter, I find, of having a process. My colleagues who all of a sudden have a patient who is presented to them and they want to do the work, and so they come to me for advice, I will give them all the advice they want, but I'll also say, read the Sherborne guidelines, because they really are straightforward, meant for primary care. It's not a tome. It's something that's quite readable and covers all the things that you have to think about, has some very practical tables. And the Rainbow Health Ontario, so you want to provide hormone therapy, it takes you through, and it's based on the Sherborne guidelines. That's another good resource for people.
Do you folks have any other ideas on some of the consequences that can come from this lack of confidence in providers to proceed with care?
There's so many different consequences, like people not getting the care that they need. That might be because they can't access it or they're waiting. Providers are omitting parts of their care. And even if that isn't the case, patients can tell. Patients can feel when their providers are uncomfortable, and that's going to affect how they experience their healthcare and things like trust and comfort.
Mm-hmm. I'm just thinking of the instance where I was going to my family physician to get paperwork filled out for approval of gender affirming surgery. And there was even a first-year med student observing, and I was saying that I wanted to do this. I was starting testosterone and everything, and his response was, and he's weighing his hands back and forth, saying, "Are you an or And I was like, I use they, them pronouns. And I still don't know that he knew what that meant, but yeah, it's awkward. The language wasn't there for him.
Part of it is that, you don't have the language for it. You don't know how to talk about this if you've never talked about it before.
Right, and then that puts you in a position where you have to explain yourself.
Yeah.
Which is something that a lot of people experience when they're accessing care, feeling like they have to educate their providers.
Mm-hmm. This is something that in my research I saw come up again and again, is this experience of realizing that the provider in front of you just doesn't know what to do. And sometimes that shows up in really subtle ways. So people describing things like awkward pauses after disclosing gender identity. There are other times where it's much more overt. Some people report providers refusing to touch them during exams or reacting with visible discomfort. And then something that I saw come up as well was even when providers mean well, those interactions can still be shaped by underlying biases. So, for example, some patients described being told things like, "You pass really well," which might sound like a compliment to the provider, but can actually feel pretty uncomfortable to that patient. And really, the one thing that stands out across this literature is what tends to happen as a result of that. What happens next? And when providers lack knowledge or experience with transgender healthcare, the responsibility more often than not shifts onto that patient. So many of these studies have described people having to educate their healthcare providers during their own appointments. That might mean explaining things like basics of gender identity, correcting assumptions about anatomy, or explaining the medical aspects of gender affirming care, like hormone therapies, the different types of surgeries that are available. So instead of being the person receiving care, patients often find themselves becoming the teacher in that room. Having to constantly advocate for yourself and feel like you have to become your own expert just to navigate the healthcare system is a lot. And that kind of dynamic really takes a toll. People describe feeling frustrated, exhausted, and rightfully so. Unfortunately, this pattern is not just anecdotal, it's consistently documented across studies. Researchers have linked these experiences to increased psychological distress and worse self-rated health outcomes among trans and gender diverse patients. And unfortunately, we see a lot of healthcare avoidance that comes out of this.
I'm fine, she, her. I sort of have this tendency where, say, I'm going to be interacting with a provider. If they're not going to be addressing me as me, I'm not going to necessarily seek out care in that capacity. I was putting off going to a dentist for a long time just on account of I didn't have one that actually acknowledged me by anything but my dead name, right?
Trans and gender diverse people frequently avoid or delay seeking care because of past negative interactions, like being misgendered or dead named, or however discrimination comes up within those clinical settings. And this isn't just about discomfort in the moment. There are real downstream effects. Across Canada, we see trans and gender diverse individuals experiencing higher rates of chronic physical and mental health conditions, and there's growing evidence to suggest that avoidance and underutilization of healthcare plays a very significant role in that. And AJ is actually going to dive much deeper into this in another episode, where he explores how these patterns of avoidance connect to health disparities. But before we move on, I wanted to share a quick experience that really reinforced some of my own worries about accessing care as a non-binary person. There was this moment in Emerge that has stuck with me to this day. There was this trans patient who had come in, unfortunately, after a suicide attempt. And I was in this central area where staff are charting and discussing patients. And one nurse referred to the patient and said, she, I mean he. And another nurse corrected them and said, actually, it's they. And then that first nurse responded, you know what? I don't really care. Nothing was said after that. The conversation just moved on. But as someone who is non-binary and uses they them pronouns, hearing that, especially in a space where someone is at their most vulnerable, really stuck with me. It wasn't said to the patient directly, but it still mattered. It spoke to the kind of environment that we create and how that can shape the care that people receive, even in ways we don't always see. And in that moment, I felt kind of sad, you know? It's those small things that also build up as much as the big things. And can truly impact how care is accessed and whether or not it's accessed at all.
I'm Pascal Joel. You can also call me PJ. I identify myself as a transmasculine, non-binary, gender fluid person, and I really don't care about my pronouns. There is definitely a lack of education, and it's starting to show a lot because more of us, the community, are speaking on it. We are kind of at a crossroad now where there's that chunk of people that just want to have that check mark next to I did the training for diversity, equity, inclusion regarding to gender. And that kind of overshadows the few folks that are there to actually learn and wanting to implement changes and make stuff better. So it is unfortunate to see, but it is a reality that we have to work with. And it's now, how do we work around that? How do we ensure that those folks are seeing the impact of, oh, I'm just going to check the boxes? And I am a big proponent of asking why. I don't remember the original person that said it, but I heard it through Dean Graziosi. And it's an exercise that you do to go basically from your head to your heart. I kind of do that with everyone that I see that I have a discussion with. I'm like, why do you think like that? Why is it just a check mark?
Pascal brings up a really important point, and it makes me think of something that we've talked about before amongst ourselves about those visible signs like stickers and posters that signal inclusion in a clinic, for example. For many people in the queer community, those markers do matter. There are some folks that find them as a first indication that the space might be safer. But unfortunately, it becomes a challenge when, like Pascal mentioned, there are things that some folks might do just to satisfy a checkbox.
I think it shouldn't just mean that you're not going to actively discriminate against someone.
Yeah.
It should imply that you're going to take steps to make sure that your practice is a place where someone can feel affirmed and feel comfortable. If you have a poster that says, "Ask me my pronouns," then you should be providing your pronouns. And if you have a bunch of pride flags, then maybe think about the ways that you can actually help patients. Do you have a space in your records where you can put a preferred name? Do you have a way that that name is what shows up when the desk calls your name? Make sure that they're seeing that preferred name and calling that name. Because if it's just buried in the chart and they're calling you by your dead name, not only is that not affirming, but you've kind of made someone feel at ease by putting up these posters and then done something to kind of take that trust away.
Yeah. And I think that's where this idea of checkbox learning becomes really important to talk about, because when the focus is just on completing a module or attending a session or putting up posters, for example, it doesn't always change those underlying assumptions. And when those assumptions go unexamined, they don't just disappear. They show up in the way that we're taught, in the comments that get made, and the moments that stick with us. We were doing a Foley catheter skills session, and we were working with mannequins, and we had a mannequin that was masculine presenting, and then under the gown was a vagina. And when I lifted up the gown to start doing the Foley catheter, the nurse yells, "Surprise!" And I was like, you know,
Was that necessary? Yeah.
Exactly. But also it's that point of there's an unconscious thing that just happened there where you have folks who are not necessarily part of the trans community or gender diverse community that now took that phrase and put it somewhere in their brain.
Yeah. Yeah.
And
Subconsciously, you embed whatever you hear and what you see, like, oh, surprise, which means that, okay, that's not normal because it's a male presenting face and a vagina. Therefore, it's not something that is normal. Just those few comments are reinforcing the binary and not just being able to be in our own bodies. And it's happening more than we think, because then it's those ideation go to the workplace. And then what if it's a real patient? And are you going to yell surprise? Are you going to think it because it happened? And then are you going to judge that person because of it? There's so many implications.
When you go through these experiences, it makes you take a step back to look at the overall picture. And that's where we begin to think more intentionally about how trans health shows up in our curriculum.
When trans health does come up in our education, it's usually as part of psychiatry or sexual health. And where we think things could be improved is instead of having it be in these specific units, to have it integrated throughout the curriculum so that it's something that people are seeing over and over again and not just as a little add-on that's tacked onto other units. And specifically to kind of move it away from sexual health, because that is a lot of times where it comes up, and sexual health is very important, but trans people need healthcare that's beyond sexual health.
Yeah, and I feel like it being tacked on to sexual health a lot of the time makes it seem like this thing that you only have to worry about if you're working in those kinds of spaces or working with that specific population.
You want to normalize the transgender identity and gender diverse identity in the sense that those people exist and you're going to interact with them in some way, shape, or form, and it doesn't mean that they're there for a sexual health related topic or psychiatry. And I think also another thing too is it kind of continues that perpetuation of the pathologizing of trans identity. And that's the framework that we're taught within. It doesn't just shape how we think, it shapes the environments that we create and whether or not people feel safe to be open about who they are within those spaces. And importantly, I feel like that sense of safety isn't something that trans people should have to navigate on their own. And I think that's where cisgender students and currently practicing providers play a big role. We need allies to be the ones to be integrating the usage of pronouns, for example, in their introductions to patients. Because I know myself, more often than not, I wouldn't use my pronouns because I use they, them pronouns. And there's that continued sense of vigilance, I guess, when you're interacting with patients, when you are part of the gender diverse community in that sense. You do have to vibe check whether or not you feel like you're safe enough to express your pronouns, and that's where allies come in.
Mm-hmm. Another thing is, as a student, there's also the element of outing yourself to preceptors who you think might not take you seriously or respect you as a learner, or who might treat you differently if you do out yourself as being non-binary.
When we talk about pronouns, it can't just be something that's expected of trans and gender diverse people, because when we're the only ones doing it, it stops being a norm and starts to be a signal that we're different. I remember one of my tutors mentioning how she noticed that pronouns became less and less used until the point where they were no longer used in second year.
Yeah, that's a great point, Sam. Like, I felt in first year, they definitely put an emphasis on using your pronouns and kind of inviting the patient into having that conversation and making them feel comfortable to share their own. But in second year, the clinical conversations became more in depth, and we were still working with a limited time frame of maybe 10 minutes per patient interaction. I will say some clinicians that I worked with, they didn't emphasize that as an important part of the conversation as it should be emphasized. So I would say that's very true.
My name is Mitchell, or Mitch, and I'm in medicine at Dalhousie University, and my pronouns are he, him. I even find myself now not doing that, like, to be honest, especially in the hospital setting. I think in Med 1, we're all learning, we're all trying to do the right thing. And then the pressure of the system, I feel like you start to feel it in, like, definitely Med 3, but even Med 2, I found people less so using pronouns. I do remember in Med 1, in skilled clinician, using pronouns, introducing myself to patient and trying to broach that conversation of my pronouns are this, how do you identify yourself? And then having some simulated patients push back against, the pronoun piece of it. And so we had conversations that with my preceptor, how does she approach that in clinic setting and stuff like that? And she made a good point that for her clinic in family med practice, all her forms will always ask pronouns. So it just kind of becomes, everyone gets asked that question. If they don't answer it, then you don't necessarily need to pry at it, which I thought was like, yeah, that's a good point. Some people might not be comfortable to answer pronouns. Other people might just be kind of pushing back against, which is not great. But it's, at the end of the day, patient-centered care.
It matters that others choose to share their pronouns too. It shifts that responsibility away from people who are most at risk and then creates that environment where gender diversity feels normal rather than exposing. Over time, those changes will result in creating spaces that feel safe enough for someone to fully show up as themselves. So where does this all leave us? We've heard about the consequences of the gaps in education, providers feeling unprepared, care being deferred or referred unnecessarily, and patients feeling like they have to carry the weight of their own care. When we look at the evidence, it's actually quite consistent on what works. Across multiple studies and curriculum evaluations, one of the clearest findings is that isolated teaching is not enough. When trans and gender diverse health is delivered in a single lecture, or only embedded within sexual health or psychiatry, it can really reinforce that idea that this care is niche and specialized and ultimately separate from what core medicine is. What consistently shows better outcomes is longitudinal integration.
Right, and this applies to other health programs as well.
When you're talking about chest expansion, that's when you talk about chest binding. When we're talking about thoracic mobility within our MSK class, that's when we talk about top surgery. When we're talking about hip mobility or lower abdomen, that's when we talk about bottom surgeries. Just having it more integrated throughout physio education as a whole, instead of being like, today is the day that we talk about 2S LGBTQ healthcare. If you have it throughout, that's going to be a better way, a more efficient way of educating healthcare providers on the needs of queer and trans peoples.
We noticed pretty quickly that there were areas in our curriculum where more education on trans healthcare would fit really well and where things could be improved and changed.
Another consistent finding across the literature is the value of community involvement. Trans and gender diverse individuals participating as educators, whether through patient educator models, panels, or curriculum design, are not just adding perspective, they're contributing to essential expertise in that area. Learners have reported that these experiences increase both their understanding as well as their confidence in that care.
And we've seen some of these effects firsthand with some of the work that we've done. We kind of got swept up in a bit of a whirlwind, and it's honestly pretty incredible to think about what we've done in the last 2 years. But thinking back, it all started with our community engaged service learning project.
Yeah, exactly. We took on this opportunity to work with Pride Health and essentially created this proposal to look at ways that we could improve trans and gender diverse health within the province itself.
Right. And the proposal was based in evidence that we had found while looking into ways to make positive change. And our project was a success. People were very enthusiastic about the changes that we recommended. But then the question was, who's actually going to make those changes?
Yeah. And it came down to us. Like everything, there's a lack of resources and people to implement some of those changes.
Yeah, and I think after we did all that digging and came up with this step-by-step plan, we felt like it had to be done. There was this evidence saying, these are actionable things that you can do to make noticeable change. We couldn't just leave it at that.
Exactly. And we've had a lot of support along the way.
We started with a plan to gather information. We created a survey for providers to share how comfortable they were and how much knowledge they had around trans health. And we gave that to Pride Health, and they might distribute that across the province. And I feel like that was kind of just dipping our toes in the water.
Yeah.
And then after that, we went all in and did a curriculum search.
Yeah, that was a lot of work.
We found all of the places that trans and gender diverse healthcare came up in the curriculum. And we looked through areas that we thought it would fit really well or areas that we thought it was obviously missing. And we ended up updating 10 pre-clerkship tutorials to include more cases with trans people written by trans people, but also more information about gender affirming care and trans health. And then we added questions to encourage students to reflect on barriers to access to care and that sort of thing.
Yeah, and I think it was important to find tutorials that, again, moving away from, like we talked about earlier, this idea of things being within sexual health or within psychiatry, and finding units that most people don't actively think about how trans health is involved, and find ways that we could incorporate those moments of thinking, like you mentioned.
For example, there was a case where the patient was diagnosed with VTE, and the case was discussing anticoagulation and that sort of thing. And we added a question that asked whether estrogen therapy in the context of gender affirming hormone therapy increased someone's VTE risk. So we added a lot of questions to get people to start thinking about these sorts of things. And that involved also writing the answers, which involved doing a lot of research and coming up with evidence-based answers for the tutorial questions. So that was a lot of work.
Mm-hmm.
And the third thing we wanted to work on was giving students an opportunity to practice having conversations with trans patients and giving them a safe space where they could make mistakes. We worked with the Med Sim interest group. That's a group that gives extra simulation practice for students. And we created a case and then acted it out.
Yeah, and our goal was to have a case about a trans patient written by trans students to help simulate discussion about how assumptions about someone's anatomy might change the way that you approach their care.
And students actually, throughout this simulation and the discussion afterwards, really appreciated this reminder to check their biases and keep an open mind. And so that went really well. And we're really hoping to get this incorporated into the skilled clinician curriculum instead of just being an optional interest group activity. And the fourth step was definitely the biggest of the four. We really wanted to bring this discussion into a more interprofessional space since gender affirming care is interprofessional. So we actually just created an entire IPE course, which is an interprofessional education course. These are courses that all students in health programs have to take. It really depends on the program, but for example, they may have to take one every semester.
Yeah, so we basically built the course to include 2 online asynchronous modules. These modules focused on 2 main areas, one being gender affirming hormone therapy and the other being gender affirming surgery. We had a mix of different modalities within the modules themselves, some audio and video content from various providers throughout the province to address these topics and provide their input on how different professions are involved within these aspects of care.
It was very encouraging to see all of these professionals who do incorporate this kind of work into their practice.
After that, we had an in-person session for the students to come and discuss cases that we had written up, and then discuss the ways that their different professions might be involved within different aspects of those cases. That was followed with a panel discussion, and folks were able to ask questions of our panelists who day in and day out provide gender-affirming care, and it all went really well.
Before the course, 35% of the students said that they felt confident in their knowledge of gender affirming care. After the course, that bumped up to 65%. We got a lot of really great feedback from the students saying that they learned a lot from each other. Having these interprofessional discussions was a very good way for them to learn more about the topic and gain a better appreciation for the expansiveness of gender affirming care.
Yeah, and we even had comments from folks saying how much they believe that this should be a mandatory component in their own education so that we can move beyond just creating safe spaces.
Just remember, things only change if somebody changes them.
Maybe that somebody can be you. Thanks to all of our guests who shared their time, expertise, and lived experience with us in this episode. You'll find more information about our guests along with their work and relevant resources in the show notes, where you will also find references, additional learning material, and a full transcript for this episode.
You can contact us at genderqueriespod@gmail.com or find us on Instagram at genderqueriespod.
That's all from us at Gender Queries.